Welcome back to Intracranial Regulation. We're going to finish up with a little more pathophysiology and just how the normal nervous system works. When you're thinking about your patients and level of conscious changes and intracranial regulation, you need to remember and be cognizant of their reflexes. You need to be thinking about the deep tendon reflexes, or DTRs. With that knee-jerk reaction, it's that afferent stimulation from the tendon being stimulated with a reflex hammer. So it's something that the patient can't control. So you know that when you check someone's normal DTRs, they will respond. Someone with increased intracranial pressure or something wrong with their intracranial regulation, maybe a stroke, a hemorrhagic problem, their DTRs are going to change. They're going to be laxing. They're not going to be able to respond. So you know that if you're losing your reflexes, your patient's getting worse. If you have hyperreflexia, which means they move much more quickly, much more briskly, then something else is wrong with that as well. So with your peripheral nervous system, remember you have cranial nerves. There are 12 pairs of spinal nerves. The cranial nerves are numbered using the Roman numeral system, so you can recall that from dosage calc. So it's going to be numbered 1 to 12. It talks about a little bit about the vagus nerve on here. The thing you need to remember about the vagus nerve is that when there is vagal stimulation, that's going to be your patients. Maybe a really great example is the elderly patient that's straining on the toilet and they're trying to have a bowel movement. So they're straining and they end up interrupting that supply to their brain. And so they have a quote-unquote vagal response. They sort of pass out, then they wake up, they're beside the toilet and don't really know how they got there. So that's kind of an important nerve to remember and to be thinking about. With your cranial nerves, it is not an expectation that you know all of these cranial nerves, but there is a handout that I will give you in class that has a nice little phrase that goes along with it, kind of can help you remember what they are. I'm just quickly in your IGGI book, page 912, you'll see that it talks about the olfactory number 1, optic number 2, oculomotor number 3. Trochlear is 4, trigeminal is 5, 6 is the abducens, 7 facial, 8 is the vestibulocochlear, number 9 glossopharyngeal, number 10 the vagus nerve that we kind of just talked briefly about, number 11 is accessory muscles, and number 12 is the hypoglossal muscles. All of those are going to be really responsible for things going on in the patient's face, looking at your perla, those types of things. So just take a look in your book, like I said, and you can find a little bit additional information. When you're looking at this side, the cranial nerve mnemonic, what you will see, this right here, I will give to you in class, so you do have a copy of it. So don't stress, don't panic about trying to write that all down. I'll give you that in class. With your spinal nerves, there's 31 pairs of spinal nerves, and these are going to be important when you're looking at someone that has like a spinal cord injury. We're not talking about spinal cord injuries in advanced concepts, but it will continue on when you are in critical care next semester. So when you're looking at this, the spinal cord supplies the body with 31 pairs of spinal nerves, and they're named according to the region where they're located. So you have thoracic, lumbar, and sacral. The thing with the spinal nerves and peripheral nervous system that I want you to be aware of are the dermatomes. And when you're looking at these pictures up here, up on your slide, with the dermatomes, what you will do is when you have a patient, say, that has an epidural or a spinal, an interthecal, when you check dermatomes, that's where they're able to feel and not feel. So someone that's had a spinal, hopefully the grand idea is that they aren't able to feel really anything below where that spinal has been inserted into their back. Typically it goes into the lumbar area and they can't really feel anything from the waist down. So when you're doing dermatomes, if you test their legs by, say, touching them lightly or with an alcohol swab, they won't be able to feel that. But as you move up on the body, then they will be able to feel that as they go to areas that haven't been affected by that nerve, or by that spinal, I'm sorry. So you can take a look. These photos are located in your Iggy book. That's really about all I need to talk about with the spinal nerves. Age-related changes in infants and children. Think about the fetal period, and the fetal period is really a rapid time of fetal growth. With your neonate, they have very primitive reflexes, so you're not going to be able to do the knee-jerk reaction checking those things. So with your neonates, the things that you want to be cognizant of is that are they able to suck? Do they have that rooting reflex? When you put a bottle by their mouth, or a mom is breastfeeding and she touches the baby's lips, do they respond appropriately? Do they open their mouth, turn their head toward that? The stepping is when you actually hold a baby up. They tend to mimic steps, so it's kind of like going up and down the steps. The Moro is also known as the startle reflex, and then Babinski. The Babinski should be positive until about 2 years of life, and that's when you stimulate the sole of the foot from the heel toward the toes, and that results in dorsiflexion of the great toe and fanning of the other toes. You also want to be cognizant of the newborn's cry. With increased intracranial pressure and things going on inside their brain, rather than having what we call a lusty cry, they'll have a very shrill, high-pitched cry. And with those types of sounds, those are the things that you need to be aware of. Or if it's absent, obviously that's not a good sign. So babies with maybe shaken baby syndrome, where that brain is sloshed around inside of their skull and they have damage to their brain. So really be paying attention to cries. Head circumferences. Infants and children that have hydrocephalus, and maybe they have shunts put in to reroute that cerebral spinal fluid, making sure that we measure the head circumference appropriately is really important, especially if they have a shunt malfunction. With children, assessing their fine and gross motor skills is important. Assess the language and speech. What are their personal social skills? Identifying benchmarks or milestones, making sure that those are appropriate to the age. Not all deficits will mean increased intracranial pressure, but it could be related to a fetal alcohol syndrome, autism, attention deficit with hyperactivity, just plain attention deficit disorder. Maybe there's some cerebral palsy. They've had an anoxic injury during labor and delivery. So not everything is going to mean that you have something bad going on in the brain. With our elderly, or as we age, with aging, we know that things tend to slow down. So if you think of an older person, comparing them to a younger person, obviously with age we tend to slow down. Many changes are going to occur with aging. Some are going to be readily visible, and others are internal, and you're not really going to know that, such as the sense of smell, the sense of taste. They decrease with age and with years. Deep tendon reflexes maybe not be as brisk as what they were, so you might see a little slower response. They may not move as smooth and fluid as you and I do, so they kind of have the stoop posture, short shuffling, unsteady gaits, those kinds of things. Okay, so we're going to stop here, and we will pick up in class the first day that we meet, and we will start talking about alterations in intracranial regulation. So when you come to class, actually this slide right here is where we're going to be starting. The previous slides before can be listened to on the voiceovers, and if you have any questions about them, please don't hesitate to ask, and hopefully you're prepared and ready when we meet the first day in class and start discussing intracranial regulation.